And welcome everyone. We're excited to kick off our new FAFP webinar series this afternoon and glad for the excellent turnout. We also thank all of our members and sponsors for your ongoing support of FAFP. I just want to start with a few housekeeping items. Please make sure that your video and audio remain off throughout the duration of today's program. We'll ask Keith to answer questions from the audience at the end of his presentation. And we have a team of volunteers who will be monitoring the chat box and facilitating your questions with Dr. Schneider. So please do be sure and enter any questions you have directly in the chat box. We will also be recording the program today to post on fafp.net. Many of you know that we were supposed to have our annual educational conference in St. Augustine a few weeks ago, where we would have celebrated our 75th anniversary. We're lucky that many of the excellent presenters we had lined up for our conference have agreed to present in our webinar series instead, but please do save the date for May 17th through 19th, 2021 for next year's meeting in Orlando, which will be extra special. Our first speaker in our webinar series today is Dr. Keith Schneider. Keith is a longtime FAFP member and a professor in food safety microbiology at the University of Florida. Keith received his BS from the University of Florida and MS-PH from University of South Florida's College of Public Health, and his PhD in food science and human nutrition back at UF. His current research area focuses on produce safety, examining survival and intervention strategies for various foodborne pathogens. He also conducts extension outreach, which includes generating educational materials and conducting food safety training workshops in Florida and around the country. Thank you for joining us today, Keith.
Thanks, Travis. Welcome, everyone. Thanks for inviting me. As Travis just mentioned, first of a new series here. I'll kind of test drive this today. I first did this talk about a month ago. Actually, I'll say a thank you now rather than an acknowledgement at the end to a colleague of mine, Dr. Naeem Matzaziri, who was our resident virologist in the department, who did a presentation on our seminar on just kind of a basic COVID 101. From that, I was asked by a group of medical insurance professionals to do a kind of the same thing, just for a non-technical audience. And kind of came up with this presentation, which I'm going to show you now. And really at the time, and this was, again, it seems ages ago, but it's really just a month ago, there was a lot of misinformation coming out about how this is spread, some of the paranoia surrounding the food system. And what we're trying to do is just kind of get a talk to kind of separate fact from fiction and kind of go over some of the basics and some of the food items. And again, when I thought things were settling down, we had the WHO announcement the other day on asymptomatic, and we'll talk about that a little bit later. But basically what I want to do now is go through a kind of an overview. Here we go. And with some background first. First off, the name, COVID-19. There was a little confusion when we heard SARS, SARS-CoV-2, COVID-19. And really, again, it's a really simple way of naming. The disease itself is the coronavirus disease. It was named after the year it was first identified, which is 2019. There was some talk that it's like the 19th version of coronavirus. That was just kind of fictional. And really, it's just the COVID just stands for coronavirus disease 2019. The virus itself is similar to the one that caused the severe acute respiratory syndrome coronavirus that appeared back in 2003. This is the second appearance that of this virus, and thus the name of the virus is SARS-CoV-2. You might have heard the term novel coronavirus, and all that meant was this is a virus. It's sequenced that we had never seen before. So again, I'll probably go back and forth using COVID-19 and SARS-CoV-2. But again, we're talking about the disease and the actual virus type. So this is the structure. It's an RNA envelope virus. Again, the coronavirus is sort of the crown-like structure. I don't quite see that as again, a lot of the viruses kind of have this similar structure. but it has an envelope around the RNA material inside. It has a phospholipid layer, again, which is one reason hand washing is so effective. This is what it looks like. This is a diagram of the coronavirus, and it's very similar to the other coronaviruses, and we'll go through some of those in a little bit as well. So the origins of COVID-19 or SARS-CoV-2 started back in December of 2019 in the Wuhan, China. And you can see in the map where it was first discovered. And it was isolated, or at least they thought it was originally focused around a wet market where, again, a lot of live animals are brought together with people. It's a very kind of not a very clean sanitary environment. They have isolated this particular virus from bats, but as I'll show you in a subsequent slide, bats kind of got a bad rep on this one. But this started back in December, and then there have been reports that this might have surfaced even earlier, even as far back as August. I don't know if there's much credence to that assumption or assertion. But again, the first documented case that we have, we know about, again, is that one in December in Wuhan, China. Human coronaviruses, there's a lot of different types. Again, when we say novel, this is one that we haven't seen before. There are common types that don't cause very serious symptoms. They can cause symptoms that appear to be like the common cold. Typically, we think of rhinovirus with the common cold, but there are coronaviruses that cause cold-like symptoms. And they don't have any fancy names like HKU1. But these common human coronaviruses, again, are out there. Again, we can come down with mild cold-like symptoms. But on the left there, you see the more virulent strains. And one of the first ones we ran into was the SARS-CoV outbreak back in 2003. The sudden acute respiratory syndrome. We have the Middle Eastern respiratory syndrome, which came out about 5-6 years ago. MERS-CoV, and then this COVID-19. And there are a lot of these in the environment. Most of them don't have a pathway to humans. They're, as we'll see again in a future slide here, that again, we basically had sort of a perfect storm of events where it was able to jump from being zoonotic to actually infecting humans. Early on, there was a lot of comparisons to the flu. The flu is a different type of virus altogether. It's an influenza virus. Again, similar in structure. Again, if you look at the diagrams, it doesn't look a whole lot different. But again, it's a different type of virus altogether. The infection rate is about, well, I'm going to say pretty much the same. What we're looking at really is the mortality rate that we're seeing, and what is known as the R naught, or R sub 0, which is this value right here. And this is the ability or the reproductive number of a particular virus. Anything above 1 means it's very infectious, it's highly transmittable, and we're going to get growth, maybe exponential growth. Anything below that, again, that's one individual. If it's one individual infecting one other individual, and you can have an arithmetic rise. But again, anything above 1.1, again 1.3, you can kind of get exponential rise. So this reproductive number is very important. And if you look at the difference here, this was early numbers that the R sub naught was very high for COVID-19, similar to its cousin, SARS-CoV-1. The mortality rate numbers have been dropping, and that was one of the early comparisons. The numbers of flu anywhere from, again, maybe 0.05 to 0.1%, and early on we were getting numbers around 3 to 4%. That number's dropped to about 1, and as we get more testing performed and we get an accurate case infection rate, infection number, that case fatality rate will probably go down. But again, you can kind of see the numbers here, and what we're looking at is really the ability to be passed on. One of the factors that really aids is kind of a long incubation time. People can be asymptomatic and or pre-symptomatic, and that's kind of the crux of the whole WHO announcement yesterday. It can take anywhere 4 to 14 days. So if you're actually shedding the virus, and again, you're not showing symptoms yet, compared to say flu after 1 to 4 days, again, your chance of passing it on to an individual unknowingly go up. So this number here, again, also contributes to a really large number of cases. And again, we've seen that number's gotten quite high. So the spreading mutation, again, we have this virus emerging in December, and there's 30,000 sort of base pair units when we look at the genome of this particular virus. And right now, it's fairly conservative. There's not a whole lot of mutation, and there are several different variants, but as few as 11 different base pairs have been changed. So there's not a whole lot of variability in the genome of this virus, but we can actually tell, based on these small little changes in the genetic material in the RNA, where these viruses occurred. The first case here in the US, which shows up in Seattle, again, seems to have come in again across the Pacific, while a lot of the East Coast cases came from the spread from central China into Europe, where we see mutation, and then that mutation comes over, and then we see it spread to, again, the East Coast, where we see the largest epicenter around the New York tri-state area. The same strain, again, is the one that's showing up in South America, and right now Brazil's under severe impact right now. Matter of fact, they just overtook the US in number of cases this week. So again, this is kind of the spread and how we can kind of tell how the virus is spread. And one of the reasons is, again, we live in a fairly global economy. It's really easy. In the space of 24 hours, we can nearly circle the globe with nonstop flights from Sydney to London now. An infected person literally just has to hop on a plane, and it can spread anywhere in the world in just a couple of days. And that's what appears to have happened. Another term we heard early on was flattening the curve, and this is kind of a graphic representation. And again, you've probably heard this to death, but just to kind of illustrate this again, without intervention, that R sub 0 or R naught goes up. We start getting a lot of transmission. We don't go into any of the lockdown, mask wearing, isolation type, and the spread becomes very large. You get our values, R naught values of 3, 4, and we get exponential growth. We get to a point where we overload the healthcare capacity of a particular area, and we saw that in really only in the New York area, where we kind of overloaded the medical facilities. Those people aren't getting adequate treatment. We have a very high mortality rate until literally we reach a point where everybody who's going to get infected has been infected. So super high mortality rate, and then we get this die off as we sort of generating herd immunity just through, again, exposure. Early on, their efforts were put towards flattening that curve, which basically means slowing the spread by isolation, mask wearing, hand washing, all the things that you heard of early on. And to get to a point where we're not overloading the healthcare system, thus the mortality rate goes down, but the total number of individuals may in fact be the same. And the other unintended consequence of flattening the curve, as you see on this chart, is that the duration of the outbreak is greatly extended. So the payoff or the trade-off here is, again, getting through it really quickly, suffering high levels of mortality versus lowering the mortality rate, but again, living with this into either, again, herd immunity takes over, or again, in the case where we're looking at, a vaccine giving time for a vaccine to be generated. So this is the worldwide cases here. confirmed cases, and again, this number changes. It's amazing how fast it changed. When I first did this talk, literally 4 weeks ago, beginning of last month, all these numbers completely changed. We passed 7 million cases. We have over 400,000 people have died that we know of. There is some question of whether or not we're getting an accurate count. And interestingly, in Europe and in North America, we have fairly good health reporting systems. In certain areas of the world, you may not get accurate counts of how many people. So this number may actually be very much underestimating the total number of cases and deaths. Also, the number of deaths, it depends on if there are other comorbidity factors. Again, people may be dying of heart failure, blood clots, or other things, strokes, that are not being counted as being associated with this, but may in fact be a direct correlation. So these are the numbers as they stand as of yesterday. And this comes from Johns Hopkins University. If we look at the US, confirmed cases, we're getting close to 2 million, and we may actually pass it today, actually. When I did this last month, we had only 900,000 cases. So 1 month later, we added 1 million cases to this. The number of deaths, again, as of yesterday, and this number changes on a, again, daily basis, we were pushing 112,000 people, which is phenomenal. For us in the food industry, we think about preventing foodborne illness, and that really consumes most of our lives. That number is anywhere from 1,000 to 3,000 people a year. So all our efforts are going into preventing those 1,000 to 3,000 people, or getting that number as low as possible. Here is a public health issue that is claiming 30 times that number, or anywhere from 100 to 30 to 100 times that number every this year. So that's a phenomenal number of people who have died from this particular pandemic here in the US. And again, we have very good healthcare in this country, but you can tell just by the distribution here, some of the metro areas have been really hard hit. And again, it's a very large number of people. We're going to be approaching the number of all the deaths from Korea, Vietnam, and every war since, in totality, just in this year. So it's still a significant problem. It is not going away anytime soon. Good news is that the numbers appear to be going down in the whole, but as you'll see in a couple of slides later, they're going up in some areas. So again, we're still in the midst of this, and by no means are we out of the woods yet. One of the things we look at is per capita. And again, if we look at some of the metro areas, large cities like Denver, again, the tri-state area around New York and New England, again, we see a lot of deaths per 100,000 or per capita. In some of the more rural states, we see very low numbers, and again, people are more spread out, and we see fewer people getting per 100,000 becoming ill and dying. So again, there's a lot to do with population density. Interestingly, we have not seen that in California. We do have a large population around the LA area, and the LA metro area has not seen the same type of death rates in illness cases as we've seen on the East Coast. So how do we compare to other countries? And we hear about this on the news, and excuse me. One of the things, you say we have more deaths than anybody else, and that's true. The converse argument is, well, we have more people, and that's true as well. So what we have to do is kind of look at the deaths per 100,000. So as we look through this map, again from Johns Hopkins, we have a couple of very small countries like San Marino, and again, see very small numbers. Andorra, very small country, and their death rates are very high. We're about 10 or 11th on this list, where we're getting roughly 34 individuals per 100,000. Again, fairly high number, but again, it puts us around 10 or 11. When we take a look at that for some of the developing countries or the countries with larger populations, we're seeing we're about 5. United Kingdom is really hard hit. We don't hear a whole lot about the UK. We've heard a lot about Italy. We've heard a lot about Spain. We're hearing a lot about Brazil and the US. Interestingly, the UK has the highest mortality rate, which is crazy per 100,000. Being on an island, fairly high population densities, especially around the London metro area. Again, you would expect that. And again, when you look at it per capita, it really stands out. Okay, so this is a moving graph, and hopefully this will work. We'll give it a shot here. So this is new confirmed cases versus total confirmed cases. So this kind of gives you the rate of how fast this spreads and when we start to see it disappear. So you notice, and China's a big one out here, you notice it was growing exponentially, and then we see this sharp decline as they shut down. Then we see this return a little bit. So as we see this, you see as some of these countries are opening, we see them drop back down and we see them spike again. But remember, this is on a logarithmic scale. So if we're looking at China here, we're talking about, 20, 30 cases versus where they were a couple of weeks ago, about 10,000 cases per week. If you look at the US, we were at a high of around over 120,000, 150,000 cases per week. And we've been on a steady decline, which is good. The problem is we're not seeing this steep decline where it's dropping off. And again, we're sub 100,000 new cases per week. The interesting thing is Brazil has surpassed us. The US is no longer leading the world in new cases per week. Brazil has passed us. I think they've hit over 150,000, where we were down to about 120,000. And again, this goes up until June 8th. So we're about 2 days behind now. So if we look at, I'm going to go right here. I'm going to do the US alone here, and I'll see if this will run. So here's all the states, and again, a selected states, not all the states, just I picked a handful of the larger ones. You'll see a precipitous drop in New York right now as we come up the end, all the isolation. But look at Florida and Texas. All of a sudden, we're seeing a bounce back. So when New York is going down, Texas has now had more new cases, and Florida has as many or more than New York does. And that's significant for a couple of reasons. So I'm going to run this again, and I'm going to isolate just those states. Let's see if this will run for us. And I'm only going to get it at the very end. You'll see New York start to dip down very quickly. And Florida's kind of holding steady. And then we see this uptick right around Memorial Day. And there you go. So New York's dropping, Massachusetts dropping. California is still on a steady increase, maybe plateauing. And then we see these slight bounce back right around Memorial Day for Florida and Texas. This is interesting for 2 reasons. One, either we're testing more people now, and people who didn't know they were positive before are learning that they are, so the number of cases, confirmed cases, goes up, but the actual infection rate really hasn't changed. Just our knowledge of how many people who have been exposed has gone up. Or 2, you've opened up the economy. We're having these mass gatherings, especially around the Memorial Day and again around the protests, where large groups of people coming together, and we're seeing a spike in the numbers. Both plausible scenarios, both concerning. Again, we are, in fact, if these numbers continue to go up, it may signal the fact that we may be in for a second wave. So how is it spread? And this obviously, again, this slide should have changed it again from what came out yesterday. But going back to some history, the primary host was thought to be a bat. And there was this big thing, well, people shouldn't eat bats. This route of infection now doesn't seem to be what is considered to be what has happened. You might have heard about the pangolin. The pangolin is a cousin of the armadillo. It is a highly trafficked animal in China. And in this case, you might have a coronavirus from a bat and a pangolin getting into a person, and then that person shedding that virus either back into the animal kingdom or to another human host. So some combination or recombination of a coronavirus seen in nature ends up creating or mutating into a novel coronavirus, SARS-CoV-2. We get into a human host, and then through large aggregations of people, and again, around these wet markets, you have large number of people, very close proximity. It spreads through travel, and travel being so global these days. And since there's such a long period for incubation, you may be asymptomatic for 10, 14 days. You can travel a far distance in that period of time where you couldn't in the past. And we see this sort of exponential growth around the world. And then again, at that point, we start to get into some intervention. In this case, remdesivir seems to be one of the meds currently being applied. But again, social distancing and mask use, isolation, hand washing, those are the types of things that help slow the spread of this particular disease. Interestingly, we've had pets become infected. We've actually infected our pets, which is kind of weird. So we have this virus mutate into something that can infect humans from the animal kingdom, and now we're able to give it back to our pets. And then we've also been able to infect large cats. We heard about tigers getting, and again, in the midst of Tiger King, we have tigers getting COVID-19, which is kind of crazy. In all, around the world, 3 dogs, 8 cats, 8 large cats, and 4 mink farms, of all things, have shown positive cases of coronavirus. There's no evidence yet that these infections to animals can make their way back into the human population. So your dog can't give it to another person, but we can give it to the dog. So that's a good thing. Again, we don't want this going out into an animal vector that we have here. Again, them getting infected from us is bad, but if they were to then be able to become a vector for it, it becomes a lot worse. It could really greatly increase the spread through the US, actually through the world, period. This particular virus seems to be airborne or through respiratory tract. And again, it's funny what's considered airborne and what's not. Basically, when we cough or sneeze, we're spraying out water droplets of various size. Some of them are light, really light, and they can stay aloft for hours. Depending on the size of your virus, if it's suspended in a drop, if it's very, very light, it can remain for hours and circulate through a room. And this is one of the common things when we think we're going on a plane and getting sick. Really, it's just getting that recirculated air and being in that confined space with these very tiny, tiny water droplets and things like, again, rhinoviruses, again, are classic where they can spread very easily. Things like Ebola, on the other hand, are fairly heavy, larger viruses. They tend to not travel very far. They're in larger droplets. They can maybe go 3 feet max or so. It's believed coronavirus can travel between 3 and 6 feet. There's some debate of whether or not a large enough dose can be gotten further away, and there's some evidence, I'll show you a slide of that in a bit, that it can be transferred further away. So when we're looking at the major route of transmittal through the population, what we're seeing is person to person, typically through these respiratory droplets getting into the mucosal membranes, whether that be eyes, nose, mouth of another individual, and again, infecting that individual, and then the cycle starts over again. And again, this is a common slide I use in my class all the time. Literally, we're told to cover our face when we sneeze, and again, I know everybody has their own experience of whether being at a restaurant or a supermarket. And when you see people sneeze and not covering their mouth, people doing, we call the Dracula, or they're sneezing to the corner of their arms, their coats. But again, an unchecked sneeze can reach anywhere from 60 to 100 miles per hour. Those droplets can stay aloft for hours. But even so, if you were to sneeze, then again, all those viral particles are now on your hands. And again, touching your eyes or anybody else or coming in contact with individual people can then get onto that person, and they touch their eyes or nose or mouth. And at that point, we can spread this quite rapidly. This is why we heard all the recommendations for hand washing early on. We had these droplets that get on our hands, or again, just through contact through the mucosal membranes. And again, we touch a surface, and possibly that surface ends up being a means for transmitting that virus, a fomite, that can transmit the disease to other folks. Now, looking at the case studies that we've seen, objects or fomite transfer to persons seems to be very, very low. Doesn't mean we shouldn't wash our hands. We should always be washing our hands. Again, that's one positive we may see out of all this. We may see a reduction in foodborne illnesses just because we're washing our hands more. People are finally listening to that message and washing their hands. And hopefully that won't stop when this stops. But again, we're seeing a very low potential right now, at least from the case studies that we've, the folks at the CDC and others have looked at, that the fomite transmitter to person is very low, and it's person to person is really where the main risk of this disease or contracting disease really occurs. This is what I was talking about, how these droplets occur, and this is an example, and then we have a diagram of a restaurant here. We have airflow here in a restaurant, and then it comes back around, and we get airflow coming back through the center to these air conditioning units, and then we have another one here, which would be on the east side of the restaurant here, and then we have airflow coming back, circulating around. So in this particular case study, we see this pattern. This individual who is sitting at table A is our patient 0 for this restaurant, and if you remember the diagram, the air comes around this way and it comes back to the middle. And depending on which way the air was blowing, we seem to have this airflow going from this individual here to the persons in closest proximity. These are the people, this is when they came down with signs of illness, going down to these individuals to where then it gets respread to the back. So even though this person's sitting here based on the airflow, we have a pattern of this transmission literally going north and then back south again through the room. So again, social distancing works, but again, if you have an aerosolized droplet, again, you can spread it around an area. And there was a study done on some buses in China. They have since redacted that study, but it was sort of showing the same information and the same sort of pattern for other types of airborne disease we've seen in airplanes. But again, this is kind of this pattern where airflow and the speed of the air greatly is going to influence how far. So where in a still room where the air is not moving, 6 feet may be more than adequate. If we have actively moving air through a system or a room, the viral particles may travel further. And we're going to have to wait and see when further studies are released. So going back to work, how might that look? And we're reading all the articles of all these meatpacking plants and some of the incredibly high rates of infection going through some of the plants that are out there right now. What we're seeing in these operations, again, less than 6 feet from the person next to you, and sometimes you're literally almost shoulder to shoulder. And then we have people across a conveyor line, and you might have 4 to 6 feet going in this direction as product is coming through. We have cold, damp conditions. So, and in this particular, we have a really favorable environment for the virus surviving for longer periods of time. We have close contact. We'd expect to see a high infection rate, and we do, to the point where, again, we're having lots of workers, a large portion of workers in these plants showing illness. Now, one way we can make it better was, again, separate out workers. Again, if this is the best we can do, again, masked and gloved, and a lot of these plants are already doing that, and no workers on the other side. We're cutting production down literally in half in this situation, and maybe even further than that if we're slowing the line down, because we have less people that can stand on that line. This requires no intervention other than slowing that line down. So production slows down, but we can reduce the potential for making somebody sick just by distancing. It should be good, better, best. But a better way of doing it is actually having a partition between the two individuals. And you may have seen this go into a supermarket. Again, we see these plexiglass partitions between the workers and the customers. And this, again, provides a level of increased prevention. But again, depending on the airflow through the system, depending on how high that plastic wall is, you may have airflow going up and over a barrier. So it's not a 100% by any means. What it does do, though, is, especially if anyone sneezes or coughing, anything that's directly in the line of fire to that other individual is going to slow the rate of infection. So in this case, again, we have the same number of people working, probably the same line speed, but again, the risk of infection now is one step lower. What we could do, again, you see in the bottom one there, we have the same number of workers as the original. We have a barrier between individuals, and then we have another partition between or across the row. In this case, where production flow is almost back up to capacity, we have a fair amount of protection. Again, it's not 100% by any means, but again, it's better than obviously having nothing above. Not everyone has symptoms. This was a study out of CDC. I think the current number is around anywhere from 80 to 85% of the people who tested positive have been asymptomatic, which means they're not showing any signs of illness or had very low signs. And that's, if you think about it, in most diseases, really dose is going to make the poison here. So not everybody who comes in contact with the virus is going to start presenting symptoms. They have to be susceptible. In the case, some of the at risk for these or comorbidities being obese, diabetes, high blood pressure. If you had any of these risk factors, again, you were at higher potential for showing symptomologies. Again, this is a study out of Georgia. 1 out of 4 did not have any of these comorbidities. So seemingly healthy individuals were getting sick. But the people who are showing symptoms really only make up a very small percentage of the folks who actually have or have come in contact with COVID or SARS-CoV-2. So it's one of these situations where it's kind of hard to tell. And again, WHO came out, I think it was yesterday, the day before, and saying that the asymptomatic individuals are not a major source of infection. It really depends on your, I guess, semantics here, what you think is major. They backpedaled a little bit and said that asymptomatic transmission accounts for about 15 to 16% of the total cases. To me, that still is fairly high, a fairly significant number. But the vast majority, 85 or so, of the cases that we see come from that smallest population, the ones who are actually showing symptomology. So again, people showing illness, presenting illness, are the ones that have the greatest risk of transfer. And that makes sense. If you're sneezing and coughing, you're more likely to spread this if you're not sneezing or coughing. So that sort of makes sense. One of the things they try to do in the World Health Organization study is to determine the risk between people who are asymptomatic, who get exposed to the virus but don't ever develop symptoms, versus people who are pre-symptomatic, who are going to be showing symptoms but just haven't started to express them yet. And again, those pre-symptomatic people, again, are at a higher risk or higher ability to transfer it than folks who are completely asymptomatic. So while it's not impossible to get it from an asymptomatic person, that still does occur. The most likely way you're going to get it is coming in contact with somebody who's showing symptomologies. And in fact, the receiving individual having one of those comorbidity factors that we mentioned, but even healthy individuals can come down with it. Again, it really depends on the amount, the dose that you get, or the inoculum that you get, and your immune system's ability to fight it off. So there's a lot of factors there. But the main takeaway is the major route of infection is person to person. And we sort of knew that. It doesn't mean that we should stop wearing masks. We should stop social distancing, even if we're not showing symptoms. While it may not be the major route of infection, it still may pose a threat. Counteracting the myths, and this is what really started all this way back when. This started with a YouTube video that sort of went viral, and I guess intended. A physician from Michigan was demonstrating or suggesting that people with their groceries, one, leave them in the car for 3 days, which was shocking to begin with. Two, when bringing them in the house, he set up a quarantine area where he'd wipe them down with disinfecting wipes, and then he'd move them to a clean zone, and he'd basically sanitize all his groceries. And then here he's showing washing off produce in a sink, nice sudsy chemicals, soap sitting right there. And that sort of made us lose our minds a little bit. We said, well, how bad can it be? Well, it went national, CNN, Dr. Gupta kind of picked up on it, and he did the exact same thing, just on CNN, and said you can use any disinfectant. They're all effective. And at that point, we said enough's enough. We have to put out something here, because that's not true. One, some of the chemicals he's seen using are not for food contact. Again, the potential for them to get on food was high enough to where, again, you're supposed to, and with a lot of the sanitizers that they were mentioning, have freshwater rinses after using them to prevent possible ingestion, or in fact, getting them into your eye. And again, not poisoning yourself, or not actually, again, causing any contact symptoms like getting chemical in your eye. Not all of these chemistries have been tested. And again, something on a smooth surface like the top of a can, that might in fact be effective. It's a non-porous material. Those sanitizers have been tested on non-porous surfaces, but their ability to disinfect a virus particle on a cardboard box is really unknown. There's really no good studies, and a lot of the disinfection studies, by the way, have been done. All the data that we're seeing really comes out of studies that were done of the original SARS outbreak 17 years ago. So it's not a whole lot of work, if any, has been done on the new strain of this coronavirus. That probably will behave similarly, I would imagine. But again, nothing was ever done for its survival or its removal from surfaces that, again, are porous. Now, what has been done with some of the previous work, well, we'll go through this, and then I have some survival data. So one of the first things that the CD came out with, and so did FDA, kind of back them up on this, is that there was no evidence for this being foodborne. So if it was on a food product, leafy green, tomato, whatever, the likelihood of you ingesting that, even though it's passing through your mouth, one, it's not going to affect you through your gut. And in fact, there's very little evidence that even the handling of it and the ingestion of it while it's coming around those mucosal membranes, the ability for it to infect an individual is, again, very, very low. It's not a major route of infection. And while it's not impossible, the risks were very, very low. And that was a good thing for food. If this has gone foodborne again, it would have been, it could have been a lot worse than it is now. There is some evidence, though, that the coronavirus can actually colonize the gut. There are ACE2 receptors in the GI tract, and we don't exactly know what that particular mode of infection, if it has any type of clinical symptomologies. We'll have to wait and see. But as far as being able to produce COVID-19, the actual disease, we have not seen any or very low evidence that food, the containers, or the packaging is likely to transmit it. So again, the abilities of these fomites to transfer or present disease or cause disease is extremely low. And again, we've gone out there and get the word out. Again, we didn't want people to be afraid of food. Really, the main way of keeping this down is, again, if we're going shopping, to wear those masks and trying to keep as much distance between us and our fellow shoppers. The food itself is very low, if not zero risk. So what we were finding then was a lot of this information of leaving groceries out for 3 days in your car. And that was shocking. We should wash your produce. And you saw our friend there washing this produce off in the sink. There was soap in the sink. Is he washing with a detergent? What was he actually doing? So one, perishable food should never be left out unrefrigerated. It's interesting. I've done a lot of different talks about this on news outlets and stuff. People go, who would be stupid enough to leave the food out in the garage for 3 days? Never asked that question. We've gotten many phone calls of people who, again, were very afraid of their food and figured leaving it out would be a good idea. Again, even our friend from Michigan, again, got a lot of criticism because, again, people started doing that. And he put out a second video saying, yeah, by all means, never leave perishable food. That should never be done. The other thing, though, is that even shelf-stable foods can degrade, and especially in the summer heat. And we weren't super hot way back in March and April, but it was hot enough here in Gainesville that shelf life and quality issues could sneak in, which would force you to go to the supermarket even more, which is what we were trying to avoid in the first place. So really, storing your food outside was sort of a bad idea. But at least they came out with an update to kind of clarify that. The other issues, I'm gonna go back here, was, again, should they be washing their produce? And let me go back one slide. The washing the produce in the sink, again, was kind of a head checker as well. The use of certain chemicals, obviously, you never wash produce with soap, especially dishwashing soap. You can get GI problems because those produce can actually absorb those chemicals, can lead to stomach distress, and again, put you in the hospital, whereas, again, the last place you want to be is around sick people and when you're trying to avoid a virus. So again, the other thing is when you're washing produce off in your sink, you have to sanitize your sink first. Again, with food-safe chemicals, and not to just load up your sink with water and thinking that it's clean. You put all sorts of raw meats and other things into your sink, and if they're not properly sanitized, all you're going to be doing is trading a potential viral pathogen for a foodborne pathogen. And now that we know that it's not necessarily transmitted via food, washing it off in an unsanitized sink, again, there's really no good reason for that, to do that. So survival on surfaces, and this came out literally right as this hit, going back, looking at the survival of, or the recovery of COVID-1 and COVID-2. Off of different surfaces, things like copper and stainless steel, cardboard and plastic. On some of these hard surfaces, we saw die off with really rapidly. Its ability to infect, and not die off, basically inactivating the virus. These virus particles being able to infect a cell literally goes down dramatically within the first 8 hours, and literally within about 24 hours, we're sort of at the limit of detection what we can see. Same thing with stainless steel. It drops off precipitously after 24 hours, and about after 48 hours, we're unable to recover active viral particles. Cardboard, same thing, drops off rather quickly. It becomes unrecoverable after 24 to 48 hours. In plastic, we do have some recovery out to 72 hours on this. Again, the significance of this are debatable. Whether, and this goes with a lot of foodborne pathogens as well, the fact that I'm able to recover them in the lab does not mean I have a large enough dose that is going to elicit a disease or an infection in an individual. So the ability to transfer from this surface, even if it's active, again, its ability to actually present that disease or elicit that disease in a person is very low, if non-existent. So that's a good thing. And again, this is just kind of restating that there's no evidence, and if there is transmission, it's low enough that it's not on the radar screens just yet, which is a good thing. Not all disinfectants are created equally. This is one thing we got a lot of questions on. People said, should I use the bleach wipes? Well, there really aren't any bleach wipes. The popular brand of bleach wipes do not contain bleach. They contain a benzylammonium chloride, which a lot of people don't know, which was interesting. It says, well, the CDC says I should use bleach. The interesting thing is that people using these to wipe their hands off and clean their food things. And again, if you look at the label, even the warning labels on the packages say if it comes in contact with food, it requires a potable water rinse. You should not be ingesting this chemical. So even the instructions say if I'm going to use this surface and it's going to come in contact with food, it needs to be rinsed. It needs to be rinsed off with a potable water rinse. So a lot of the disinfection wipes, contrary to what was said on CNN, not all disinfections are created equally. Some of them have definite gastrointestinal consequences. And again, if it has a warning label on it, keep out of reach of children. Again, think twice about, again, wiping your food off with it. What we were telling people, what our recommendation was, we're looking for products with EPA registration numbers. Again, it's not the only chemical. We just happen to have this label available. We're looking for this registration number for it says that it's what it's good for. And again, this says it's for hard non-porous surfaces. It says nothing about cardboard. This particular one is hydroperoxide and peroxyacetic acid, standard PAA type solution. Again, there's very low toxicity with this. We have a use solution concentration that we know of that we can use this safely. And again, we know that because it's registered with the EPA, it is safe for food items. And again, there are instructions to be followed. The end list that came out that was published by EPA gave a list of chemicals that you could use. Our recommendation was, again, look for that EPA list, read the use instructions, and making sure that you're not using a harmful chemical on something that you're going to ingest. Again, that could be worse than, again, coming in contact with the very low potential of contracting COVID-19. Our recommendation, again, was what we normally would do. If we're going to rinse our produce off, we can use just running water. If we want to rinse stuff off the surface, or if we wanted to use a chlorine type solution, a bleach solution, we can use something like a dilute solution of sodium hypochlorite bleach, and that comes with its own problems. We'll talk about it later. Just to kind of show you the confusion that this led to when these videos came out, the calls to poison control centers began in March, and you see the jump of the approximate number of people. The call centers used to get about 300 calls a month on average. It jumped up to about 500, almost doubling. So it's one of those things where, again, too much information was a bad thing. People were just wiping their hands down with chemicals they shouldn't have been wiping their hands down with. They were combining chemicals that should not be combined. And in fact, they were making things worse for themselves when it really didn't present that big of a risk. One of the worst cases we heard about was a woman who mixed vinegar with bleach. And can be a deadly concentration or combination. A brief overview on chlorine chemistry. Sodium hypochlorite, which produces HOCl in water, hypochlorous acid. When you add bleach to water, you end up with a combination or ratio of hypochlorous acid and hypochlorite ion. And as you add more bleach, what ends up happening is you tend to drive the pH in this direction. You end up with a preponderance of OCl minus and less of the HOCl. The bad thing about that is that the HOCl is the active form of sodium hypochlorite. It's what is doing most of the cleaning. While OCl minus is slightly efficacious, my colleague compared it to a 44 Magnum and a 22 or a BB gun, stopping power. This is not, while it has some, it's not nearly as effective. And as we add more and more chlorine, it becomes less and less effective. So in most commercial applications, we always talk about adding an acidulant to our to our bleach solution and trying to keep that pH right around 6 to 7, and we kind of get this range right in here where we have roughly half in the active form and half in the less active form. What this individual did is they added vinegar, drove the reaction in the other direction, and started to elute chlorine gas. and she almost asphyxiated herself. So by mixing chlorine bleach together with bleach and vinegar, ended up producing chlorine gas and almost killed herself in the process. So you never mix vinegar and bleach. Same thing, we don't mix bleach and ammonia. The producing of harmful off-gassing, again, can actually lead to serious repercussions. In this case, she nearly died. The other issue with bleach is that since we don't want people to acidify, because again, that's kind of especially in small volumes, it's very easy to over-acidify and end up with chlorine gas. What the CDC recommends is using basically 1/3 of a cup per gallon, which yields about 1,000 to 2,500 ppm of that free chlorine in the water. The problem, though, is that as you add that much chlorine bleach to a water solution, you drive the pH up to around 9 or 10. Everything is in the inactive form or the less active form. Thus, we need much more of the chemistry to do the same amount of disinfecting if we had a properly acidified concentration. So CDC is really using a brute force method here of using a very high concentration of very or less active form of bleach, but taking the potential for causing harmful chlorine gas emissions from occurring. So again, they're using a very high level of chlorine sanitizer, which again, at that point, you have the potential, especially if you're using that level of bleach on produce, effectively maybe burning the leaves or actually causing off flavors, and again, the ingestion of potential chemicals. And again, sulfate hypochlorite has some disinfection byproducts, but yeah, that's an excessive amount. We would never use this in the industry. That's way too high. And again, still requires a water rinse. Okay, the Lysol hoax was another one that we heard about. And here it is. If you look on the side of a Lysol wipe, it's effective against human coronaviruses. You see, this is the deep state government conspiracy. They knew about it. They created these wipes and then released it on the unsuspecting public. No, if you remember back to my 3rd or 4th slide, coronavirus has been around for a long time. We've known about them for about 50 years or plus. There are common human coronaviruses, ones that cause things, again, just like common cold symptoms. And these Lysol wipes and other disinfectant wipes have shown to be effective against those, which is great. This has by no means meant that that they've already been tested against SARS-CoV-2, but again, just they proved to be effective at inactivating the human coronaviruses that were used in the testing of these products. And again, those are kind of those less active, less virulent strains that we talked about earlier. Other methods that we heard about, UV ultraviolet light C. Again, this high energy UV light. There are certain air cleaners out there that use UVC as a sterilant, and typically the range of UVC, there's a range that actually can damage your DNA, so you want to limit the exposure of anywhere from 250 to around 280, we can have cellular damage. Even exposure to these shorter wavelengths around 180 to about 230, 240 nanometers. Again, less likely to damage DNA, but you still don't want to have a long-term exposure, especially to the eyes. Again, you can have breakdown of the cells. You're not going to have the damage to the DNA that we're seeing with those higher wavelengths. But again, UVC has been used in air cleaners and air scrubbers for a very long time. Again, one of my favorite restaurants here in Gainesville has a UVC air cleaner discreetly mounted behind their drink dispenser. And again, a lot of HEPA air filters have a UV bulb inside of them that helps kill or inactivate biologic pathogens as they go through the filter. So again, they can be very effective. Other things that we heard about, mass doses of vitamin C, drinking lots of water, garlic, whether you be ingesting it or wearing it around your neck. We heard shaving off your beard. I've taken an anti-stance to that. Mouthwash, hand dryers. So there was a lot of misinformation early on. And some of it was just people just making up stuff. Some, in the case of certain chemicals, rinses, toothpaste, were just scams to get people's money, which is kind of awful when you think about it. But again, there's a lot of misinformation, especially in the area, this age of social media. you can spread misinformation very, very rapidly. In the case of some of the washing the produce and using these chemical wipes on your food products, again, potentially led to, again, people making themselves sick. In the case of the one woman, again, and several people actually who mixed chemicals together, led to hospitalization. So good thing is I don't think anybody has died from that. But again, we don't want to make the problem worse. It's already bad enough. So take home points from today. Good news. SARS-CoV-2 is not transmitted by food or food packaging. And if it is at a level that is not significant, that's being tracked right now. So that's not the main way of getting this. Again, for susceptible individuals, heat will inactivate it. It's like any other biologic, whether it be bacteria, parasite, or virus. Heat does a really great job at breaking down this. And again, it will, I don't want to use the word die, but inactivate with heat. So if you cook something and you're worried about this virus or any other foodborne pathogen, again, heat's going to get rid of it. A lot of the sanitizers that are already out there are probably going to be effective once the testing is done. The structure of this virus is very similar to its cousin, SARS-CoV-1, so I'd imagine the test done with that would be fairly similar, if not almost identical. So many of the sanitizers that are already out there are probably going to do just as good of a job. And really the best strategy still for preventing COVID is still social distancing, the wearing of masks, and in lesser extent now is and hand washing. But all the things that we've been doing up to now, again, just limit to the person contact, and spreading that disease that way. So that's still our best advice moving forward. So with that, I know we're right up about the hour. Oops, sorry, 2 minutes over. I'll be happy to answer any questions if there and out there. I haven't been watching the chat, so Travis, if you want to let me know if there's anything out there.
Thank you. Actually, this is Jamie here. So we did have one question from Jason. Could you comment on how Sweden's approach of not locking down succeeded or failed?
Yeah, again, so, that was the case where the government thought they had it all figured out, that they just wouldn't lock down, and it didn't work. It's one of those classic cases where not jumping on the problem early led to more illnesses. And you saw it here in the US, you see it now in Brazil, you see it in Russia. Really, if we're going to prevent the spread of any type of respiratory disease, again, early action is going to have the most effect. By ignoring the problem or thinking it's just going to go away, unless you're a very rural country where the social distance between people is far, and again, New Zealand is not a very heavily populated country, and they jumped on it early. They're a success story in all this. And again, Sweden's decision not to do that. Again, you can see the consequences. Same thing with Great Britain. Boris Johnson was, business as usual until he ended up in the hospital. It sounded like it was touch and go there. Now he's sort of a believer. Don't wish bad times on anybody, but I think Boris could be a champion for COVID or COVID prevention. So,
thank you. We had another question from Richard regarding UVC. Would you care to comment on airborne particles providing shields for pathogens going through?
Yeah, you can get shadowing. Any type of UV, it's distance to the bulb. That's a big thing. The energy of the light obviously drops off inversely proportional to the distance. So most of the airborne scrubbers are usually tied with some type of HEPA filter. So one, if it goes through the filter, the UV is going to help it building up, and again, will kill anything that comes in contact with the bulb or passes by. The filter itself should filter out the larger particles. Anytime you have something on a foam-like dust particle, water droplet, depending on where it is, and since viruses are in the nano scale, especially on dust particles, again, they can be hidden in shadow from a UV light source, no problem. Which is why, again, if you're going to have a UV light, you should have some type of filter. If not, again, it reduces the efficacy of that system.
Great. And then we just had one more question that was previous to the webinar here from Peter Hibbard. What alternatives are recommended for self-quarantine or for testing that would allow the employee entrance back into the food service operation ASAP? My understanding is 10 days self-quarantine with the last 3 free of fever and symptoms without fever-reducing drugs or referral to a medical doctor, and then tested and negative in order to return to work. Before self-quarantine period, what has worked best for you?
Well, I don't own a business, so I don't know. I don't have any direct answer what works for me. What we're seeing is that when workers are brought together in large numbers, we have a large spread of disease, and that's what's happening in a lot of these meat plants. A test is only as good as the day that you take it, and I've been tested. As a matter of fact, I had both tests done just from own personal edification. Wanted to see if I had COVID, and I had a bad cold and a sinus infection back in March. So I'm thinking, oh, I might have gotten it. Let's check, and I didn't. But that day, I knew that test. So this was 2 weeks ago. I think I had this test. So am I COVID free now? Well, maybe not. I mean, I just went and got street tacos today for lunch for my favorite takeout place, and I may have contracted it today. I can come in contact with an individual. So a test is only as good as the day it's done. Unfortunately, again, even the doctors don't. Same thing. You go see a doctor. Yeah, I'm COVID free for that day. The very next day, you might come in contact with somebody, especially when you're, again, in a large industry area where people are maybe socially distanced at their workbenches or their stations, but they're filing out either through a vestibule where they're changing their clothes, they're stamping their time cards, they're getting on buses or getting in carpools. And at that point, all the efforts in distancing at work are really for naught. So really, I think self-reporting and isolation, just like we would do normally, would probably be the most effective. Again, if somebody has symptoms, especially fever, which is one of the classic symptoms, they shouldn't be at work. Screening, maybe on entry, anybody with a fever not being allowed into work. Obviously, anybody who's showing signs of stuffy nose, coughing, sneezing, again, shouldn't be allowed to be around other workers. Self-quarantining for that, it's 10 days, maybe 14 days. And that was Dr. Fauci's thing when he came in contact with somebody who's his self-isolation for 14 days. So I don't know if that answers the question. I think the testing is great. It allows us to tell the rates of infection, calculate that R0 value. But again, that test is only good for that one day. And as soon as you go and come in contact with other people, that test is no longer valid because you might be infected that day.
Thank you. That's all the questions I have for right now.
Okay. Anybody else?
Thank you, Keith, for your presentation today. And thanks to everyone who joined us. And remember that we have additional webinars planned every 2 weeks. So our next one will be on June 24th with Joetta De Francisco from FDAX, and she'll be talking about the regulation of hemp extracts. And then we have webinars planned every 2 weeks through September 16th. And we are looking at the possibility of additional webinars. So if you have any speakers or topics you'd like to volunteer, please get in touch with us on that. And that concludes our webinar.
There's one more question on masks. Masks are about 75% effective. I still wear mine. So it's one of those things where it's not 100%, 75 is still better than 0. So that's my opinion on masks.
All right, thanks everyone. Thanks, Keith.
Thanks everyone. See you later.